Way kind words, way too kind, in fact. Thank you, Rod. But had a great time at Harborview. But being here and as you're setting off in your careers, it's just a true privilege to sit in front of all you bright minds. And again, it's humbling to see a Sunday course at the end of 2.5 days to be this full and to run a caboose lecture in front of such an engaged audience. So really cool. Thank you for being here. So you've hit rock bottom of the spine when you're at the sacrum, but literally and figuratively. Okay, so conflicts should not be present, but I will be presenting some of our data. And again, in terms of the sacrum, we've had a fantastic vignette lecture with anatomy dissections and demonstrations by Dr. Kostwick. So this is kind of tying upon that in terms of looking at the sacrum maybe a little bit differently in the future, looking at the emerging field of classifications, and we're not done yet. So Dr. Anand's excellent summary of the classifications continues and treatment options. And again, one of the key things in the sacrum is that's been the forgotten bone for, I think, all too long. It's been on the literal and figurative intersection between the trauma surgeons, the ortho-trauma world, and spine surgeons, the forgotten kind of a bone. It's so easy to overlook these things. And you could facetiously ask, why bother? We've obviously talked a lot about the alignment. If you look at this little epigram of John Dorman's picture, on the left, this tells you what's going on there. This is again showing you how the sacrum really ties into the overall spine alignment. And when there are collagen disorders, connective tissue disorders, and other factors, it really sets the stage for problems. And what you don't want to have is a disaster as the one on the right side with a spondylolaptosis and a completely dysplastic sacrum. And this is an end stage of what a neglected sacrum will do. This is a patient whose sacrum is actually popped out of the skin through an insufficiency fracture we took care of at Harborview. And this was a complete, utter mess of a neglected sacral fracture of over a year's duration. So you don't want to let it come to this. There are two categorical entities I want to conceptualize: the high speed, high kinetic energy one, and then the insufficiency problem. And in polytrauma, probably about 30%, a full 1/3 of patients have some form of a posterior pelvic ring fracture. And it's telling how widely disparate the literature is, and it's again a reflection of how insufficient our data gathering tools are. The second entity are the sacral insufficiency fracture. And again, this is a growing concern of ours, especially as we're becoming better at putting hardware in, and probably maybe also more liberal in putting hardware into patients and trying to get pelvic fixation. And again, I urge you when you're home to maybe click on Dr. Kostwick's lecture, which Jason will put online probably within a day or so, and just get his little tidbits and become enlightened into your practice. One of the big other problems is that we don't know how to examine it, and we come back to Neil's excellent point of examining our patients. I mean, frequently we're really dealing with catastrophic situations when you're in a level 1 trauma center, just trying to keep hemodynamic stability going. And again, then orthopods will frequently put in these clamps or something like that, which diminishes the ability of stabilizing the spine. Another problem is that we frequently don't appreciate the open injuries. Again, this is a crass picture, and I apologize for that, but it is unfortunately usually intravaginal in female patients or rectal injuries that are missed when we have open pelvic ring fracture. So that should not happen anymore. And again, it's up to us, who are spine care providers, to provide that expertise and that determination to make sure this is assessed properly. The other factor that is frequently overlooked is the posterior soft tissue contusions, and I'll show you some pictures about that later. One of the simplest things you, as whether you're neurosurgeons or orthopedic surgeons, can do when you see a patient who is not resuscitating well and has an open book pelvis fracture is to actually sheet them. So after, emphasis on AFTER, bold letters, after a physical exam, including vault exam of rectum and if present vagina, you have to basically then sheet the patients and to make sure you have a stable pelvis. This is the simplest tool in the world, and you'll be amazed how much volume decrease of the pelvis you can actually affect with this. So examine the patient. I don't want to dwell on what we frequently consider the basics in terms of the neurologic examination, but one thing that really bothers me is the lack of rectal examinations. And when I was teaching medical students, the term I did not want is rectal exam normal. There are 4 dimensions to it. You can all read it for yourself, and they should be accounted for separately. It's a simple checklist nowadays on Epic frequently, but these are the things we want to look for. And as Dr. Tubbs yesterday identified, they all relate to various stages of the sacral plexus. So I urge you to become more differentiated. It's actually, again, when you see all these questions like Neil telling you to examine the feet, these actually go very fast once you become cognizant of them. It's just the enlightenment and the determination to detail. Plain radiographs, again, this is probably something that we'll not have in the future anymore because of increased emphasis on CT scanners being integrated in the time-efficient evaluation of patients. But there's an art and there's a simple kind of conceptual perception of how pelvises look on radiographs. And again, in clinic settings, we usually still have to rely on radiographs. So we still have to know what a pelvis AP looks and what an inlet and an outlet looks like. And this is an inlet view where you basically look into the pelvis, and an outlet view where you see the sacrum en face, so on face. A completely overlooked view, which I just don't understand why we overlook it so much, that you can get in your clinic is a sacrum lateral. Just have the radiologist penetrate, point to the S3 area and shoot a standing lateral. And you can, again, see the sacral morphology of fractures or of patients standing. CT scanners, obviously everyone knows it, and we need to look for the reformats, and I do urge you to insist on getting coronal reformats so that you can see these kind of sacral fracture patterns. For me, the 3D models are always cool to show. I've stopped showing my videos because in clinical reality, I literally don't use them. Neuroimaging is something that is still emerging, and again, MRI neurography, something that actually came out of the University of Washington initially from Jade Saruda, is a compelling view, especially as we're entering a new era of being able to visualize nerves. And this is why we put the non-commercial startup lecture this morning into play. I think that we have some very near opportunities to actually visualize nerves better than ever before. Please do know that CT myelography is not very helpful usually in sacral fractures. Why? Because the dural sac usually in most patients ends between S1 and S2. So the lower sacral neural anatomy you can't directly visualize. There are a number of radiographic measurements, and again, I'm not going to bore you with that, but I want to point out this little left and right sacrum lateral view. The pleomorphism of the human sacrum is still poorly understood, and we have patients who have a very straight sacral surface, and then we have patients with a corniform, meaning a hook-shaped sacrum. So I hope that you'll come out of here learning to understand the plasticity of the sacrum and appreciate it in terms of what it does. Gesundheit. Are you all right? Am I making you allergic? It's not an anaphylactic response, right? One thing that I also want to point out is that you want to learn how to understand the sacral height and again the mid-sagittal diameter in terms of fractures. A little pointer about sacral neuroanatomy. Again, that's one of those overlooked points. The take-home point I want to bring to your attention is the S1 foramen. So the ventral foramen obviously has the motor root in it, and the S1 root does not have a lot of room in it. So it fulfills between 60 and 80% of that foraminal space, and any fracture that goes to the S1 foramen does not have a lot of room for give. So be cognizant of that. That's in contrast to the lower sacral foramen where there's a lot of room. So the wiggle room at S4, for instance, is very high. And a impingement, a partial impingement, is way better tolerated. Finally, another word about electrodiagnostics. So EMGs, again, we frequently think they don't help us very much, but in fact, anal sphincter EMGs are a very significant helper. The classic teaching in your boards is that you have to wait for 3 weeks to get the manifestations. I have not published this, but it's a frequent observation that if you have sacral fractures, you can actually get abnormal anal sphincter EMGs way earlier. Pudendal SCPs are something extremely helpful, especially in intraoperative management. And for long-term assessment, post-void residuals are a absolute game changer. You have to know that obviously S2, S3 is mainly a bladder, S3, S4, S5 is mainly a rectal-dominated sphere. Now let's talk about sacral fractures a little bit. And again, here I just want to point out, I don't want you to memorize this, but I want to point out an appreciation for you as neurological surgeons mainly, but also orthopedic surgeons that's frequently overlooked. And that is learning to categorize the vertical component of sacral fractures as being either lateral, medial, or through the L5S1 joints. So Balz-Easler out of Switzerland brought this to our attention. And the take-home point for you is if you find that a fracture is lateral to the L5S1 joint, the posterior ring stability is going to be impaired. And again, you need to look at the pelvic ring stability as being impaired. If it is medial, you have a very high incidence of neurologic injuries, but the structural stability of the pelvic ring may not be impaired. So that's the key point. All of us, I hope, know of this classification, right? Is this news to anybody? The Francis Denise classification? By the way, a quick commentary on Neil's excellent talk earlier. One thing I don't want to hear personally anymore is the Denise classification for thoracolumbar fractures. Right, Neil? That we should just put that away. There is no such thing as the middle column. Correct, Neil? Let's throw that away. But this was a visionary classification. Why? It actually translates into injury severity. A zone 1 injury has its most medial category of fracture lateral to the foramina. The neurologic injury is usually L5. There may be structural impairment, but neurologic injury risk is very low. Zone 2s have made lumbosacral plexus injuries in about up to a third of patients. And the big problems are whenever any form of a fracture goes into the spinal canal, you have a half chance of having a Cauda equina impairment. To subclassify that became necessary, and again, this is Raymond Roy-Camille, who basically subclassified zone 3 injuries. So those that go through the sacral canal can be separated based upon displacement of simply kyphosis, or kyphosis and translation, or segmental comminution. A very logical, severity-based progression that's kind of intuitively clear also. What we actually do in the middle of the night is not talk about Roger or Raymond, Roy-Camille, and Denise 3. We usually talk about, right, H, U, T fractures, etc. And that's, again, the nomenclature that has become very accepted, although it's totally unscientific. So I have no problem with this, but basically just convert in your mind Denise 3 and then put a Roy-Camille subclassification in. Within AO, we've now, for the last 5 years, struggled to come with an intuitively and reproducibly clear new classification, and I think we're making some headway, but it's a global undertaking, and I'm not particularly optimistic to have something out by 2016. One thing that has been totally overlooked by the Asia classification system is the neurologic classification of the sacrum and, again, the sacral plexus. The single biggest omission when we look at outcome studies of patients is bowel bladder function and human sexuality. Those are very much on the top of the quality of life things of patients. Yet the Asia system completely neglects this. So the Gibbons system back from the mid-80s is the one that we've kind of used for our trauma work. And again, it logically progresses into bowel and bladder dysfunction on a 4-tiered level. It again completely omits human sexuality. Decision making. We want to look at stability, we want to look at neurologic status, and we look at soft tissues in a logical form. And again, appreciating and understanding the contusion and deglovement by initially photographing or very carefully palpating patients posteriorly is very, very important. Non-operative care. I mean, this is something that was the only weapon that we had in our arsenal. I was raised with non-operative care. Again, when do we do it? If it's a stable bony injury, if the patient is neurologically intact, single system, no soft tissue compromise, very reasonable to think about it. Again, we have very crude medieval methods of protected weight bearing, usually a reclining back chair, recumbent traction, and outcomes are unclear. The literature says there's an 80% chance for improvement. I'm going to show you a case, and sadly Paul Anderson had to leave to catch his plane back to Wisconsin, but I was a brand new attending in 1992, and I had this very big kid with this zone 3, Roy-Camille 3 injury come in. You see the displacement right here. It's literally all the way off. And again, looks pretty dramatic. It's as we'd now say, also frequently a U-shaped fracture. Remarkably, this kid was completely intact, and he was a linebacker kind of a guy. He fell off a bridge during a drunken stupor contest, and there was no suicidal ideation involved. I was overmatched with this kid. It turned out that he had religious beliefs against blood transfusions, so basically I was not quite clear what to do with him. I put him on anticoagulants, bilateral pantaloon spikers, and I'm still not sure how many workman's comp claims for back pain I got from the 2 months of recumbent back care that we gave him. But the final healing result is absolutely amazing. He got no blood clots. He had a perfect result. So non-operative care can work, but we had endless discussions in the process of doing this with this family. One frequent problem when we deal with sacral fractures is in the high kinetic energy mechanisms, of course, the high incidence of adjacent and other systems injuries such as abdominal trauma and extremity fractures in about 2/3 of patients. And this obviously influences our timing. What about decompression? Again, there are clear indications if there's especially a focal neurologic deficit and you expect contiguous neural tissue. If you have a completely disrupted sacrum, it obviously may not merit surgical investigation, but we've been impressed how often our nerve cells are actually resilient and actually survive significant trauma. The methods can be anything from a focal femonotomy to a laminectomy to a ventral disimpaction, things that I'm going to briefly outline. The outcomes are, again, based on literature, very unclear, and yet again we come up with this 80% number, which seems to pervade most of literature of some good or excellent results. The question is if it's better than non-operative. And here's a basic suggestion about neural decompression. Our fellows have done this a couple of times now, and I think they're all far more comfortable now. You can do a mini decompression or a ventral disimpaction by simply identifying the lateral fold of the S2 or S3 roots, ventrally dissecting in a blunt dissection the sacrum, and then disimpacting, you can see this with a shoe impactor here, the offending bone structure. And this is, again, the metal myelogram. You can basically visually see how you're ventrally disimpacting the spinal canal. This is the sad state of the literature in terms of operative versus non-operative treatment. I leave you to be the judge, but this is a more incidental description. Basically, overall, there seems to be a favorable or more favorable operative intervention outcome. Stabilization, again, when you have an unstable ring, more soft tissue injuries involved, or you needed an extensive neural decompression, that's a very legitimate form of treatment. There are multiple methods for it, and again, the main outcomes can be marred by complications such as infections and secondary neurologic deteriorations. Healing can be high, especially in patients with mainly bony injuries, and if you do your job right, pain is a factor in about a third of patients. Again, how we are doing fixation now has changed dramatically, has to be biomechanically stable. We, and I personally, challenge any surgeon to create something that is biologically acceptable to the patient, meaning low profile, but allows the patient immediate full weight bearing and reconstructs that inverted T. So the historical lumbopelvic fixation, such as in this Galveston contrast here, is really not biomechanically stable. It's an unstable kind of a semi-rigid construct, and it usually has a very high incidence of loosening. There are many, many foibles throughout history, and I was, believe it or not, trained in this particular technique of fixing a lumbosacral junction. I can only equate the pain of the patients afterwards to the intraoperative pain that the surgeons experienced, and the anxiety level was very high. Now I would tear up a whole phone book of papers probably if I had to do this again. We were trained in all sorts of novel techniques, and I remember the unfriendly ways of cutting soft tissues. One food for thought is please don't do bilateral, parasagittal incisions in the sacrum. It's a denervating incision. It basically cuts the cluneal nerves almost invariably. So doing midline incisions will get you anywhere, and being cognizant of the posterior foramen to leave the cluneal nerves is a very doable thing. You don't have to burn the whole posterior sacrum. These are actually cases that I did at Harborview in the early 90s, and again, these are Roy Camille plates where we actually plated the posterior sacrum and did little Ayler screws back then. Roger Roy Camille was the father of this technique, and it's not very stable, although we could get very nice fixation results, such as in the suicidal jumper. There were many other options. I'm not promulgating that, but this is a German technique where they basically actually saved the sacral plexus left and right of the screws. It just intuitively does not make good sense to me. Percutaneous SI screws are something that traditionally is not taught in neurosurgery, but with your skills, this is actually something that you can do in the future, and I recommend that you actually start learning about it, especially in a trauma center. This is not and should not be an orthopedic prerogative, and again, with image guidance system, this is something that is actually increasingly doable, and some of our former neurosurgery residents are actually very adept at putting lumbopelvic hardware in now. They are, again, something that cannot be done in highly displaced sacral fractures. Zone 3 injuries have to be non-displaced. They can, again, be done with a decompression. For instance, look at this case down here. There was a large sacral fragment obstructing about 50% of the canal after an SI screw was put in, and we did a mini foraminotomy under image guidance, took out the fragment, and the patient literally could walk out of there. So this is not a joke. This is a very effective treatment, but it's not very stable. And again, stability is a major problem. The pelvic ring has to provide a proper flat platform. If you don't have that, you're going to have problems like this. And I'm going to show you that in a case scenario. So you need to have a proper footing, and the proper footing for the sacrum is obviously the ilium. The person who I have, after a lot of retrospective research, really found and want to credit with that is our former fellow Thomas Schildhauer. He in Germany, independently of us, developed a very thoroughly researched assessment of how to place pelvic screws properly. He's from the University of Bochum, and he's been a visiting professor here. He has a beautiful video, so you can look at him putting them into the lab, actually, on the SSF TV site. This is the problem with SI screws. They can frequently not hold the pelvic ring and fall apart. And this is a case and example. A master of pelvic surgery put these beautiful percutaneous screws in this patient. It looked great. The patient started sitting up, and just in sitting, basically started displacing his fracture and developed severe pain. And again, by means of lumbopelvic fixation, we were able to pull the pelvis back into place again and stabilize the patient and allow the patient full weight bearing right away. So these are well published in a number of papers over time. And again, whether you fuse or not fuse the lumbosacral junction is a different topic. We have usually not fused the lumbosacral spine historically. Some patients spontaneously ankylose, especially if they have head injuries. That's an area of emerging research. Biomechanically, lumbopelvic fixation, if done right, beats the pants off anything else. This is a comparison of SI screws on the bottom and pelvic screws on the top. And when you put proper iliac screws in, you can literally let even a large patient weight bear fully right away. So what's the method? Again, midline exposure, doing a full soft tissue exposure. Remember, the only muscle that separates the posterior sacrum from the world is the multifidus. So you have to learn how to elevate the multifidus as one whole structure with a midline sacral fascia dissection, so you can completely repair the fascia afterwards in a very precise fashion. Intraoperative imaging can be done in a number of fashions, and I'll show you a couple of tricks with it. But basically, you want to put these screws in and aiming towards the anterior inferior iliac spinous process. So that's the goal, and that's the ultra-long screws. We have a number of papers on this that basically shows the trajectories that you can take towards this goal. And obviously, you want to avoid invasion of the sciatic notch with the superior gluteal artery resting right in there. Orthopedic patients have died when the SGA has been injured, for instance, in hip surgery or posterior pelvic surgery. You can actually, and we've proven this in a different paper, put 8 millimeter diameter screws of up to 140 millimeters length into males and 7 millimeter screws of up to 130 millimeter length in females. We don't have to do this each time, but this is, again, in your decision-making protocol. If you have a desperately unstable situation, you want to use full maximum screw length if possible. These are the radiographic views we use. We use a true lateral again on image guidance. You want to learn to superimpose the SI joint, the sciatic notch, so that you have a completely squared out pelvis. And again, you want to learn how to look for the teardrop view. These little diagrams that are amateurishly created kind of try to suggest the inclination angles that you do, both in terms of the frontal and the coronal planes. And you want to look at the screw insertion on this particular view then afterwards to make sure you have an intraosseous screw extension. And you want to then look at the iliac screws, such as in the right side. The iliac view here will show you how long the screws are. And here's your anterior inferior iliac spinous process. You can do it alone or with iliac screw fixation. We use the SI screws more or less as a reduction tool, and then the iliac screws as a neutralization tool. How often did we use it at Harborview? It was still an exception. That little sliver on the very top, that blue turquoise sliver, that's how often we used it compared to non-operative or purely percutaneous SI screw care. So for trauma, it's a rare but very welcome addition to where we actually use it. How well do patients do with it? Well, there are a couple of papers that we put out. We can actually reduce the sacral kyphosis dramatically. You can literally dial it in, and there are a number of tricks to use to kind of cantilever the upper sacrum back in if you need to do that, and restore a pretty reasonable normal pelvis, and yet again let the pelvis, let the patient fully weight bear right away. Bladder recovery, we actually demonstrated using the Gibbons criteria a very robust rate of neurologic recovery. And again, we had a number of electrophysiologic and post-void residual tests to help us with that. Learn again, please, or keep in mind that part of the bladder innervation comes from the parasympathetic plexus, which is shown in this model on the left-hand side presacrally. So some of the innervation may not come back. A very important insight is that even unilateral preservation of S2, 3, and 4 can restore bladder and bowel function in 80% of patients. So every little fiber there counts. Hence, again, think about surgical restoration in these patients. Complications, we looked at that very carefully, and the overwhelming problem that we saw was broken rods in a third of patients, because, yet again, we did not formally fuse these patients. We thought we had given them enough trauma yet. Interestingly, The broken rods did not at all correlate with back pain. It was just one of those phenomena that we didn't fully have an explanation for. The other big problem was infections. 17, meaning almost 1 in 5 patients had some form of a wound breakdown, and that's a big deal. We've modified things a lot over time. We used incisional vac dressings that would cover everything hermetically. We did multi-layered, meaning 3 to 4 level closures. Obviously, antibiotic powder was used, and we were far better over time in terms of containing CSF leak. Still, wound-related complications, when you have major bruising, as an actual patient of ours, or the degloving that takes place, which is in medical terms called a Morel-Lavallee lesion, are major things that we have to contend with. We nowadays recommend when you have a degloving patient that you actually just take them back, seal them with an incisional vac after about 72 hours, and wash everything out again and then reclose them. This is how bad this degloving is, which can go all the way up to the posterior thoracic rib cage. So hardware-related complications and rod breakage are something that we don't really like. We don't know how bad it is for patients. The open question is whether we should do primary fusions in these patients. The other big tenet to us is to put this very powerful hardware as low profile as we can, and Dr. Kosdrick gave you some tricks yesterday. And again, creating a recess within the ilium is a very adept way of doing this. And again, just being very aware that soft tissues are a problem. These are a couple of little tricks and schematic views. What does not work is big, bulky connector pieces, which some manufacturers have. I recommend that you don't even try that because these patients will be bothered by it and they'll probably have soft tissue breakdown. It's a very unforgiving environment and a high degree of precision is necessary. We did a follow-up technique a couple of years later, and again we considered everything, and again we identified that patients basically, when we did a more adept fusion-oriented approach, had far less complications and hardware breakdown. So that was a very big deal. Correction again could be achieved still with a new group of surgeons in all those cases. So this is a patient, for instance, 18-year-old with bilateral L5 weakness. He has a zone 3 Roy-Camille 2 injury, so it's kyphotic and slightly translated but not dislocated. This is a CT scan, again a very distal injury, S3, and in standard nomenclature in the midnight parlance, we'd probably call this an H-type fracture. The percutaneous fixation with SI screws and a trauma team. You could argue that the screws weren't very well placed. The patient on post-op day 4 had increasing pain. And again, what you can see is that he was getting an increased kind of an open pelvis view. On the CT scan, you can see with the patient at bed rest how the sacral inclination angle changed dramatically and how the screws basically pivoted inside the sacrum. We took the patient back, did a complex reduction maneuver with a variety of pins to disengage the pelvis, and we then put lumbopelvic fixation into him, and again, we're able to correct the malangulation, have the patient immediately weight bear. So again, I have no fault with the colleagues who try to pin this patient percutaneous. It's very elegant, but it's biomechanically suspect, and frequently not the best option, and had a very nice healing result with fusion. So things to avoid are, again, internal fixation for internal fixation's sake. You have to actually do a reduction maneuver and decompress neural elements. And that brings me to sacral insufficiency fractures, just in closing. This has been, again, an emerging problem for which we don't have a real denominator. They're frequently missed, and when you do a lumbopelvic fixation on a postmenopausal female, especially that patient's doing great for 2 or 3 weeks and then suddenly comes back bent forwards into clinic with increasing back pain, think sacral fracture. The earlier you make that call with a simple CT, the better to avoid displacements, and we'll talk about treatment in a second. What you really want to look for is on your pelvis AP that you get this kind of a ring view, this sudden pelvic inlet view. Why is that happening? Because the sacrum is tilting forwards, and now you know this also. And the sacrum lateral view is the best way to look at this. Again, you can all see this fraction now. This is an actual zone 3 injury with a slow displacement. So this is what you really want to learn to avoid, this kind of a secondary acquired forward bent posture. You want to teach patients to avoid that. You want them to be aware of this and avoid it wherever possible. And again, a CT scan is the best way to look at this in a very steady, straightforward fashion. Yet again, fixation is very possible and is very well received by these patients, and a reduction can still be performed. The number of lumbar levels to be included depends upon how displaced the pelvis is. This is one of those horror cases that came to us about a year out. This patient was literally in a wheelchair and couldn't walk anymore. There was no neural impingement. The sacrum had basically completely dislocated off the lumbar fixation. We've published a series under Kleinberg where we basically could identify non-operative and operative care. And again, this is one of our surgical patients in this list, and she actually has been a very grateful patient. She's donated a large amount of money just for being somewhat straight again and being able to walk. So the publication, sorry I didn't put that reference in here, identified non-operative care as possible if you recognize it early. The patients usually need about 2 months of bed rest and a brace. But you can't avoid surgery. Surgery has a more predictable outcome, and again, iliac fixation is the way to go. This is a recently done patient who had a significant impingement and complete loss of bowel and bladder control. He was severely osteoporotic, and we did a ventral disimpaction, as you can see on the bottom image, and did a lumbopelvic fixation with a very nice result. Lumbopelvic fixation is also something where pathologic fractures can be treated. This is a case that Dr. Monteith, Rod, and I did together, a hypernephroma with a very elegant embolization. This patient, who was completely unable to even lay on her back due to pain, had a very nice resection result, and we could basically reconstruct her and again let her immediately weight bear. So final thoughts. The body of our literature is again very insufficient. It's more or less anecdotal case reports. There are no larger series. Many times the numbers are actually very limited. The timing of surgery, again, is something that you, as an emerging generation, can help redefine. We usually recommend trying to do acute fractures in about 3 days, but less than 2 weeks is very reasonable. The main disability parameters are urologic dysfunction and sexual dysfunction, with pain still being a very frequently reported outcomes problem. And again, the more accurately you can reduce the pain, the fracture, the better the patients do. Return to work, about 2/3 of patients can be expected to return to their work. And again, there's some expected mental and physical impairment scale. So in conclusion, I hope that the sacrum is no longer an unknown entity for you, that you have an enhanced appreciation and awareness of it. And again, there's a lot of different injury severities to consider. Again, the posterior pelvis should not be a domain of orthopedic surgery alone. This is a shared spine and trauma territory. And again, sufficient stability is a very beneficial technique. You should be more or less aware of how to do percutaneous and open fixation. The complications, again, there's plenty of room for improvement. In the end, I thank you all for being here until the very end, and I'll ask Linda to come up here and Rod to come up here and join me at the front. Thank you very much.